Another YouTube video going on. I'm back. Featuring Shritik today.
How you doing, guys?
Thank you, Johan, for recording this video because you didn't have anything to do today, did you?
Why are you just playing me?
Today we're going to the renal system. Okay? Now, Shritik, would you like to draw a nephron for us?
Yes, for sure. Okay, so today I'll be drawing the nephron. I'll do it in black.
Don't worry, guys, you don't have to know how to draw this. It's not part of the content. Do you want me to draw for you?
Nah, this is fine.
You need assistance?
This is totally fine.
Sorry guys, technical difficulties. Draw this sticker, draw this sticker.
No, that's fine.
Think I love it. You want me to try? You have to, what do you mean? Okay, don't mind him, he's not part of the video. What is that? Okay, well back to the video, guys. Would you like to label it for us? And you can abbreviate
Okay, you can talk through it, okay? I'll tell you.
That's the afferent arterial. Efferent arterial. He's actually not abbreviating this time. You can abbreviate it, just letting you know. That's your Bowman's capsule. You just write the glomerulus after. Yep. PCT, proximal convoluted tubule. Glomerulus. Very good. This is also called the corpuscle, just letting you guys know. Descending limb of the loop of Henle. It was named after a guy whose last name was Henry. If you didn't know. Ascending limb, collecting duct, and distal convoluted tubule. We can have a DCT, it's fine. Okay. Thank you so much, Shritik. Very good drawing. I couldn't have done it better myself. Okay.
Well, there's two types of it. You remember that?
Go ahead, draw it. No.
Oh, like write it down.
Yeah, write it.
Yeah. So you have the
It's really the worst. Okay. So the whole point of your renal system is we want to filter out your blood. Okay. You have a bunch of waste products. Remember you have the important stuff: glucose, electrolytes, hormones. So if the renal system, the kidneys, are filtering out your blood, we want to keep the essential things and secrete the waste products into the renal system so it can be excreted through your urethra. Okay, that's where you pee out and urinate. Okay, that's the whole point of the renal system, right? So today, I just want to mention, this is called a nephron. It's the functional unit of a kidney. Okay, and do you want to draw the kidney for us? There we go. You have two kidneys. Your right is a little bit lower than your left because there's the liver on top of it. It's from T12 to L3. And the whole point is your liver sit at the back. They're retroperitoneal. And you have your two floating ribs just at the top of the kidneys, okay? And they have structural fat around them. This is not your normal fat, right? You have functional fat and you have structural. Functional fat means it can be used at any point in time. I'm exercising, my body's gonna do lipid metabolism to generate ATP, okay? But structural fat is literally as it sounds. It's a structure, it's our scaffold to hold our kidneys, okay? Now with really lean people, there's potential that they use all their structural fat. So end up, your body goes through its functional and then it's in a mode of starvation where it goes into a structural fat and you can actually get floating kidneys. Okay? Well, thank you so much, Shritik, for drawing it out. Kidney, it's very nice drawing. I love it. Would you like to label some now and explain?
Okay, yeah. So you got your cortex. So that's where the cortical ones are. Cortical.
Yeah.
Cortical. So they'll usually be like
majority.
Over here, just a little bit of lymph node in there, collecting duct all the way into here. So this is where the minor calyx.
Yeah, the minor calyx. The minor calyx is
And then just on the edges here.
Yeah.
And then you have the major here. That's where all of them will drain into.
Okay.
And then these are your juxtaglomerular nephrons, the ones that are mainly in the pillar.
So I just want to add, your cortical nephrons have a short loop of Henle, whereas your juxtaglomerular nephrons have a long loop of Henle that go all the way from the junction between the cortex and the medulla, all the way to the bottom of the medulla. That's how you have a long loop of Henle. Okay. Why do we have a long loop of Henle? You will see now that the loop of Henle is the majority for water and change in osmolarity. We're trying to concentrate the urine. So the longer the loop of Henle, the more we can concentrate the urine, get the go from low osmolarity to high osmolarity, so water comes out of the descending limb outside and gets reabsorbed back into our blood vessels and our circulatory system. Okay, so he talked about the cortex. What's also important about the cortex is that it's disorganized. Okay, if you see it in a thing, it looks very disorganized. Where if you look at a medulla, it's very structured. It's Henle's are parallel, so you actually see it like this. If you look at a histology slide. Okay, and then just here, at this junction here, you have something called papillary, and what it is, it's like a sieve. Okay, so after you go through collecting duct and comes out, it's like your final sieve before you go to your minor calyx. And then your minor calyx, you have maybe 3 or 5 per kidney, goes and forms the major calyx, which ultimately goes to the renal pelvis. So the renal pelvis would be here, go all the way down into your bladder, all right? And eventually urethra, all right? And you also have, this whole point here is called the renal helium, which contains your renal pelvis, your renal arteries, and your renal veins, okay? And we should also talk about that there's renal columns between these pyramids. So these are called the renal pyramids. There's also renal columns between them. Okay, these are also disorganized. They're part of the cortical or the cortex part. So they have disorganized nephrons, right? It's all over the place. It's tangled up. Okay, but the whole point is, so our nephrons are going to be filtering out the system, taking all the stuff, going through the papillary, joining at the minor calyx, will join with the major calyx, go through the renal pelvis and go all the way down to your bladder, and then it'll go, your urethra will come out, and yeah, it'll get excreted. Okay. And we have 2 of these kidneys, about 150 grams each. Yeah. Okay. Let's talk about what happens with the nephron, the functional unit, as we were talking about before. So, what's the most important thing? Secretion is going into the tubules, which means going into your nephrons. We want to get rid of it. Reabsorption is, because remember with our gut, we absorb stuff. So when I eat something, I'm absorbing its nutrients. Reabsorption is like saying you're doing it a second time. It's going back into the bloodstream. So that's what happens when you say the sodium's coming back from the nephron. So when the sodium's coming back from the nephron into the bloodstream, this is called reabsorption. It's going back into our blood vessels for the second time. Okay? Let's start with it. So you got your, do you want to help me do this? You can do the glomerular.
What?
Explain what's happening at the start.
Okay, yeah, so basically your blood will come through the afferent arteriole. Remember, afferent means going towards. So it's going towards the Bowman's capsule or the corpuscle.
Mm-hmm.
And then it's going to go through all these capillaries here. Now, one more thing that we need to add is that these capillaries, the reason that we have an efferent arteriole here is because these capillaries will go back into the nephron and it surrounds it. So that's called the vasorector. Right, so the vasorector, it surrounds this loop of Henle, ascending limb and the descending limb.
And there's also the peritubular that goes around it.
The peritubular, yeah. So the point of this is when it does get reabsorbed, like Matt said, it's through the vasorector and it goes back to the bloodstream. So yeah, so this is the capillary here. All of this is oxygenated blood. The vasorector is where it gets deoxygenated as well. And then this is the Bowman's capsule, so this is where the filtrate will enter here from the capillaries into the proximal convoluted tubule. So it'll enter filtrate from here. So if we just want to label that filtrate.
That's very good, Shritik. I'm going to try to make this more interesting when we ask you Shritik questions. Okay. I'm just
I
bored.
didn't sign up for this.
If you want, we can switch. I can do the proximal.
Okay, yeah,
Do
well.
you want me to do the proximal? Okay, so what is reabsorbed at the proximal convoluted tubule?
Okay, so.
Which is the PCT, guys.
Yeah, so the PCT, I'm pretty sure you have sodium here, or your electrolytes. So you have sodium, potassium, chloride, things like that here. But as soon as you get down to here, it stops. So over here, I'll draw it in. Just the main ones that we need to know.
What else? Doc?
Yeah, and obviously, like with this, other stuff will follow, but yeah, those are the main ones you need to know.
Also, glucose to come back in. There's also bicarbonate that comes that's get reabsorbed.
So that'll come through with the sodium, so co-transport.
Transport. But the majority of the reabsorption acts as the proximal convoluted tubule because we don't want glucose to be going into our nephron and getting excreted, okay? We just want to get rid of it straight away, bring it back into our body to be used as energy. But that comes in with diabetics, right? Because you have something called transport maximum, which is your maximum, so you have transport proteins in your nephron. And what happens is this allows like stuff like glucose and sodium to come back into the bloodstream. But if you saturate them, which is you have so much glucose or so much solute that it's not able to keep up with it, because let's say it's getting rid of 3 glucose per second, and if you have heaps of glucose, it can't keep up with that. So you're going to have concentrated glucose throughout the nephron, and eventually it'll reach the collecting duct and you pee it out. That's with hyperglycemia. With people who have diabetes, type 1 and type 2, right, and it's not being controlled well. Tell me about the descending limb.
The descending limb, okay, so over here we had all our solutes and the electrolytes getting reabsorbed, but here that gets turned off, so we have no reabsorption of solutes. The only thing that gets reabsorbed in the descending limb is water. So that is the only thing that gets reabsorbed here.
Why would it be reabsorbed by?
Yep, so that comes down to the osmolarity, or osmolality, which can be used interchangeably. Do you want to talk about that, or do you want to go through it?
I can talk about that.
Sure.
So osmolarity is the amount of solutes within a solution, okay? So if I have a lot, let's say you add salt to water, right? If I'm adding salt to water, I'm increasing its osmolarity. I'm increasing the amount of solutes within that. Let's say somebody puts more sodium in that water. That has a higher osmolarity compared to the other one with less sodium. Okay, so when we're saying osmolarity, like I said, it's just the amount of solids within a solution. And because we have going through the nephron, right, reabsorbed most of it through the proximal convoluted tubule, we actually have low osmolarity. We have low osmolarity in here, okay? Which means what? We have low amount of solutes in there. So it's mostly water. Okay. Now compared to the outside, we're saying the interstitial space, we have high osmolarity. What does that mean? High amount of solutes within that space. Remember, where there's always high amount of solutes, because it's so concentrated, there's so much, let's say, sodium, chloride in it, water will follow to dilute it. So what's happening is that's why the water is coming out from low osmolarity to high osmolarity to try to dilute and decrease this osmolarity here. So osmolarity moves from low to high.
So inside this loop, you'll notice that the osmolarity will increase. Alright, so usually these are the numbers you'll see. So when we talk back to here, we're talking inside, so we'll go in. So it'll start off at 300 here, outside, and it'll move, as it moves in, it gets more concentrated, so it'll be around 1200 in there. Exactly what we just talked about.
Okay. Thank you so much, Shritik. Would you like to do the ascending limb now? Or?
Okay, sure. So the ascending limb is, we're going back to the solutes and the electrolytes. So here, you'll see these guys again getting reabsorbed.
Yep.
And then this same effect here, you see it'll be the opposite. So as sodium, potassium, chloride all get reabsorbed, you'll see that the osmolarity will decrease again. So it'll just be going backwards at around 800, 600, 300, and it'll actually drop below. So it'll be around 100 at the distal convoluted tubule.
So what Shritik is saying is that as you're going down, the more you go down, right, the more water that's leaving this area. The more water that's leaving this area, the higher the osmolarity, more solutes in the solution. Okay, so we're moving that water. Okay. Then when we go back up, we're going back up, right? And sodium and now chloride and all the ions will move into the interstitial space. So now what are we doing? What do you guys think? What do you think? So when we're going back up, what's happening to the osmolarity?
Okay, yeah, so sodium, potassium are leaving. The solute concentration is decreasing inside the limb. It's decreasing, there's more water, therefore the osmolarity is getting low.
Okay, so it's as we're going down here, it's increasing. As we're going back up, the osmolarity is further decreasing. What is? Okay, so we went from concentrating the urine with water leaving to diluting it again. Okay, now we're going to talk about what happens at the. I should probably mention this is called the counter current exchange. Okay, because remember, it's just saying that they're going in opposite directions. In one direction, they're moving the osmolarities increasing this side and decreasing this side, right? Counter current. Okay, now we're going to move on to the distal convoluted tubule. Okay, and the distal convoluted tubule just mostly reabsorbs ions, takes some water also back in when we're going from the distal convoluted tubule to the collecting duct. So also water starts coming back because we still want to concentrate it. Okay, we'll talk about how water comes back here. This is something important there. There's aquaporins there.
Usually water won't come back. Only in the presence of ADH.
But generally,
Yeah,
just have some ADH already in our body over time.
So
So ions, yeah. So ions, water come back in this area. Okay, are reabsorbed back into the system. Okay. So we do glomerular filtration.
Okay, so we've done this.
Do you want to talk?
We've done
Yeah, we're pretty much on that.
done that.
Let's talk about
and
how.
done this.
So we know we're reabsorbing stuff. Let's see how we alter this mechanism through, let's say, myogenic response.
Okay, so about my gene.
Do you want me to do it?
Up to you.
I'll do it. So we have something called myogenic response. What is a myo? Muscle. Okay, so with everything, right? When you stretch your, let's say, your arterioles, right? We're stretching the walls. Okay, when we stretch the walls, there's actually something really cool. I learned this a couple of weeks ago. So you actually have sodium channels in your arterioles. Okay, and when this stretches, so let's say you have an increase in blood volume, it pushes on, and these sodium channels open even more. If these sodium channels open even more, it draws ions, and it results in depolarization. This depolarization, remember, goes to the sarcoplasmic reticulum, and the sarcoplasmic reticulum will release calcium. When it releases calcium, what happens? Myosin head binds to actin, allowing the sliding filament model contraction. That's what happens. So when we're stretching it out, we're opening the sodium channels, depolarization down the sarcolemma, T-tubule, sarcoplasmic reticulum, allowing calcium to enter, bind to troponin on actin, myosin bind to the actin head, sliding filament model, contraction. And so overall, the myogenic response, when there's an increase in stretch in these vessels, there will be constriction to counteract it. Okay, so we're increasing that blood pressure. We're increasing that pressure. Okay, so if we have a lot of pressure at these arterioles, right? Let's say we have a lot of pressure, right? It's what happens with a lot of pressure? There'll be a lot of pressure acting on the actual the tunica intima, the tunica media, so the whole outside boundary of the vessel, right? It will be stretching it out. If it stretches it out, this will cause constriction. Why do we want this? If there's a high blood flow, here, and that it's entering the nephron, we could actually burst it, right? There'll be too much fluid running through it. But also this, if there's a lot of fluid running through it, do you think we'll have a lot of time to take out these all these solutes and reabsorb them? We won't have a lot of time. The faster you go, we won't have a lot of time to bring it back in. So we want to slow down. We want to slow down the amount of blood flow that goes into here. So if we constrict the vessels, yes, we're increasing the pressure, but we're actually decreasing the blood flow. So when we constrict these vessels here through myogenic response, we're actually decreasing the overall blood flow. This is bad. Okay, so we're actually decreasing the overall blood flow to the nephrons. So that's the myogenic. Okay, this is very unorganized, guys, but we're doing this for fun, so it's all a teaching process for us. But you guys, I hope you guys understand the myogenic response, especially Umang, who's going to be watching this video. Also, shout out to Sahil. Should be studying right now. Okay.
Yeah.
So we've done the myogenic. What about the tubular glomerular feedback system? Go on.
Alright.
You want to go for me?
Huh? It's up to you. Like I can do it. You can do it.
I'll add anything.
Okay, sure. So you have these specialized cells called macular denser cells. Right, really important. So I'll just write it down, macular denser. Now these cells are sensitive to sodium. Alright, really important to sodium concentration. Now I believe they are here in the distal convoluted tubule, and it's really tightly measured. Right, really tight. So remember how we have around 100 after all the sodium is reabsorbed. So macular denser cells are epithelial cells, and they basically surround this tubule. They, again, measure a concentration of sodium. Now, if there is an increase in sodium, right, if they measure that there is an increase in sodium ions, what this does is this will go back over here to the afferent arteriole. Alright, and what its aim is to do is to reduce the amount of blood that is entering the glomerulus. So an increase in sodium ions means that there is an increase in blood in the Bowman's capsule. Alright? And its aim is to reduce the amount of blood entering so that it can maintain its GFR levels. GFR, glomerular filtration rate, I don't know if you mentioned it. So it'll constrict. Right? Less blood entering the filtration area. Now, the opposite happens when you don't add something.
No, I was just say it's mostly sodium chloride that it's measuring, but also that this is directly what this has. It has cells really specifically juxtaglomerular cells that contain renin. That's how it acts on it. So, like he said before, there'll be a constriction, right, and increase in blood pressure. So how we do this is it releases renin in this system. If there's a high concentration of sodium chloride throughout the system, it's going too fast. We don't have enough time to reabsorb. So we want to decrease that blood flow. How do we decrease it? Vasoconstriction. Yeah, you want to continue?
Yep, and then the exact opposite happens when there is a decrease in sodium chloride. What it'll do is it will vasodilate this arteriole to increase the amount of blood entering the glomerulus.
Very good. Okay.
Alright, so we have done this one now.
We've also done the So just the somatic.
Sympathetic, parasympathetic, and somatic.
Okay. So with the sympathetic response, remember it's flight or fright. Oh, fight or fright.
Fight or fright.
Okay. Okay. So the whole point is right. When you your system is in that flight or fright response, it wants to stop you from peeing. So it's in that survival response, right? This is a really stupid scenario, but you're running away from a lion. Do you want to end up standing there to urinate? Because I'm pretty sure you'll be eaten by the time you finish. Okay? So this is where the sympathetic response comes in. Okay? And what the sympathetic response will do is it will relax. You have detrusor cells in your bladder, detrusor cells in your muscle, and your sympathetic will relax those detrusor cells in your bladder. It will relax them to stop it from contracting and pushing out the urine. And also the sympathetic will act on the internal urethral sphincter and the external urethral sphincter, allowing it to contract to stop the movement of urine from the bladder into the urethra and being peed out. Okay, so the sympathetic response is trying to stop us from peeing. Okay, like I said, so it relaxes these detrusor cells, which is your muscle cells, preventing you from contracting and pushing the urine out, and also closes up the internal sphincter and external sphincter. All this is using norepinephrine. Okay. Now we go into our parasympathetic response. Rest and digest. Okay. We're relaxed. No lions coming to eat us. We're okay. We can stop for a quick loo. Okay. So what happens is the parasympathetic response, it will release acetylcholine. This acetylcholine will act on these detrusor cells or the muscle cells to make it contract. And the acetylcholine will act on the internal sphincter and the external sphincter, opening them up, allowing them to urinate. Okay. I want to add one more thing about the somatic response. Somatic, voluntary, right? You have control over that response. That's specifically for the external sphincter only. You cannot control the internal sphincter. It's involuntary. So the only thing you control is your external sphincter. Through your somatic response, you voluntarily open your external sphincter. Okay.
Should we just touch on the bladder, how much it should be filled for the response for you to void? So at 200, you'll get your first kind of sign from your body saying you need to pee. At around 400 is when you get the second one. The bladder can hold, I think, 500 until like you have to void. So he's drawing it over there. The storage compartment should be a little bit longer because you can store a lot of urine, and then eventually your body will say you need to void all the urine, and that's when you'll get that spike over there. So he's kind of drawing it.
So just think about it, it's increasing response. The more it's filled up, the more it's stretching those cells. You also, like the blood has transition epithelium, that's why it's able to stretch so much. So the more it stretches those cells, the more it's giving that response to you have to urinate, telling yourself you have to urinate, right? And yeah, should we touch on glomerular filtration? We didn't. Yeah, I didn't say we did. So it's just in our blood tests, we have if you see on your blood test, we'll say something called EGFR. EGFR is just your measure of your glomerular filtration rate. How much blood and how fast is your nephron or your glomerulus filtering out this blood? Okay? Just how quickly it's going in and getting filtered out. That's your glomerular filtration rate. And you can see that in the blood test if you look next time, EGFR. Okay, okay, so we have hydrostatic pressure and osmotic pressure. So the main driver of the stuff going to the glomerulus is your hydrostatic pressure. Okay, your pressure from your heart, right, when it contracts, that creates that hydrostatic pressure, allowing stuff to go in. Okay. And you go your osmotic pressure, which is actually also known as your like colloid osmotic pressure, which is just your proteins within your blood that ultimately control how much fluid is getting reabsorbed into the blood vessels. You want to do glomerular?
So this is the pressure that is caused by the Bowman's capsule that opposes the glomerular pressure. So it's created by the filtrate going into the capsule. So that's the bottom one there, and that'll leave you a net of around 10 millimeters per mercury.
Anything else we can think of? We forgot to do ADH and aldosterone.
Oh, we need to write everything.
Sorry about
That's
that.
another
Sorry, this is not very messy. This was just, we just finished the lecture now that we got taught. Okay. So, we talk about ADH. ADH is released from your posterior pituitary gland. So you got your posterior pituitary gland right below your hypothalamus and below your thalamus. That's your control center for your body, okay? And when you are dehydrated, right, we don't want to be peeing out a lot of water. So what does your body do? Your hypothalamus sends antidiuretic hormone, ADH, down into your posterior pituitary gland. That will get released, and that will act on your distal convoluted tubule. And what will happen is, distal convoluted tubule, so intellecting duct. So this will increase the expression of aquaporins. Aquaporins are just channels. They don't actually push directly through ATP or anything. They actually act as passive diffusion. What it means is that it makes the collecting duct and the distal convoluted should be permeable to water. So what that means is that if there's, let's say there's low osmolarity here, right? So we have a lot of water in here, and we have high osmolarity in our bloodstream, which means we're actually dehydrated. These aquaporins will allow the water to move from low osmolarity to high osmolarity, allowing it to be reabsorbed into our bloodstream. Okay, that's really important, right? We don't want to be peeing out too much urine. But ultimately, everything that acts with, anything that you think of acts with osmolarity, the amount of solute within a solution, okay? It always moves from low to high. Always remember that. Let's talk about aldosterone. So on the top of your kidneys, we have something called the adrenal gland, okay? And this adrenal gland, right, it releases something called aldosterone. Aldosterone acts to, it's similar to ADH. It acts to release, to increase the reabsorption of sodium within the nephron. Okay, so it increases that reabsorption of sodium. And what's really cool about this is that wherever sodium goes, water follows. Okay, so if we're increasing the reabsorption of sodium from our nephron, we're increasing the amount of water that gets reabsorbed. Okay, so aldosterone increases sodium reabsorption, but also indirectly increases H2O reabsorption. Okay, but the thing is, if we have enough sodium in our bloodstream, we're not going to use aldosterone. We're going to use ADH. We just want water. Okay, that's how we can alternate between, do we want sodium and water, or do we just want water by itself? With ADH, just water. Aldosterone is also sodium and water being reabsorbed. We haven't mentioned the RAS system. I'm going to mention sorry about the board. I wish I had an extra one, but we're low funded at the bottom. Okay. I'll just mention it. It's called the RAS system. I mentioned renin before, produced by the juxtaglomerular cells. Okay, they contain renin, and this renin acts from the kidneys, moves to the liver, right, and the angiotensin is produced from the liver. Renin acts on that to form angiotensin 1, and then we need help. We use ACE, which is an enzyme that lets angiotensin 1 to convert to angiotensin 2. And then this angiotensin 2 does multiple things. It causes the increase in aldosterone, the increase in ADH, and also vasoconstriction. Now the whole point of the RAS system is to what? The main two things: increase blood pressure, increase blood flow. Okay? So when say we got really low blood pressure, that's where our RAS system will come into hand. Release renin, aldosterone, aldosterone, ADH will increase our blood volume. And then we'll also have vasoconstriction, will help us increase our blood pressure within our vessels. So the RAS system is really important for vasoconstriction and reabsorption.
It's a really big clinical point for high blood pressure. You'll see a lot of people on ACE inhibitors. So ACE is the key enzyme in the RAS system.
So what happens if we inhibit the ACE?
So if we inhibit ACE, ACE is angiotensin converting enzyme, so it inhibits this conversion here. If you can't get this conversion, you can't get aldosterone. If you can't get aldosterone, you can't reabsorb the water and it'll go out and the blood pressure decreases.
Yeah. Okay. So that's somebody with hypertension, right? High blood pressure. We can use inhibiting of the angiotensin converting enzyme. Okay. We forget anything?
Probably, but
yeah, this is off the cuff.
Yeah.
So thank you very much.
Thank you guys.
Thank you to Johan. You want to say any thank yous?
Yeah, thank you Johan for taking the video. Also, thank you for having me on your
Anytime, Shritik. We should bring Imam and Sahil into this.
Appreciate it.
Okay.